Welcome to the deep dive. You know how it works. You send us what's on your study table, and we extract the vital insights.
Yeah, we dig into it.
Exactly. Today, we're tackling a pretty comprehensive set of MSRA revision notes on testicular cancer sent in by one of you.
Great topic. Important one.
It really is. So, our mission, turn these detailed notes into a crystal clear, high-yield understanding, perfect for revision.
Make it stick.
We'll cover everything, definition, complications, the lot. So, yeah, ready to dive in.
Absolutely. We have a lot of ground to cover, defining it right through to the potential complications. These notes are thorough.
They love it.
So let's get started and really pull out what's most important for you to remember.
Okay, let's unpack this then. What exactly is testicular cancer?
So basically, it's malignant tumor growth. Can be in one or both testicles.
And it starts somewhere specific.
Yeah, the key thing is it almost always originates in the germ cells.
Those are the sperm-producing cells, right?
That's right, yeah. Those cells in the testicles.
Okay, and you mentioned types.
Two main categories to remember for revision. Seminomas and non-seminomas.
Seminomas and non-seminomas. Got it.
They have some differences, but they both fall under testicular cancer.
Yeah.
And, crucially, this is really important, it's highly treatable.
Especially if caught early.
Exactly. Especially with early detection. That's the, a really positive takeaway here.
That's good to know. So what kicks this off? The etiology.
Well, the notes are clear on this. The exact cause remains unknown.
Right. So no single smoking gun.
Nope. So instead of hunting for one cause, it's much more useful to focus on the factors that increase person's risk.
Like the risk factors. Makes sense.
Think of it like looking at the whole landscape, not just one raindrop.
Okay, so what's on that landscape? What are the main risk factors?
Top of the list is Cryptorchidism.
Undescended testicle.
Precisely. Where one or both don't drop properly into the scrotum. Then there's family history.
So if a close relative had it.
Yep. And interestingly, a personal history having had it in one testicle before that significantly increases the risk for the other one.
Ah, okay. What else?
We also need to consider certain genetic conditions. Klinefelter syndrome is the key example mentioned here.
The extra X chromosome.
That's the one. Also, HIV infection is listed as increasing risk, and age is a big factor.
Who's most affected?
It's most common in young to middle-aged men, typically between 15 and 49.
Okay, so those are the headliners. But the notes go deeper, right? Additional factors.
They do. For a more, detailed picture, infertility, for instance, is quite significant. The notes say it actually triples the risk.
Wow, triples. That's substantial.
It is. And there's this fascinating link to development factors. Klinefelter's pops up again.
Highlighting the genetic side again.
Exactly. And then mumps, orchitis.
Inflammation from mumps.
Yeah, inflammation of the testicles caused by the mumps virus. Also, various factors around birth seem to play a role, like low birth weight or having had an infantile hernia.
And wasn't there something about height?
Yes. That's quite an intriguing one. Taller height is mentioned as increasing the risk of germ cell tumors specifically.
One to remember.
Definitely. But the single strongest risk factor highlighted is having had a previous malignancy in the contralateral testis.
The opposite one.
The opposite one. That's crucial for anyone with a history.
Makes sense. And more on genetics.
A bit more, yes. The notes point to a specific gene, TGCT1, on the X chromosome. This can increase risk massively, up to 50 times.
50 times. Goodness.
And finally, there's an abnormality on chromosome 12, which is apparently present in most testicular tumors. Suggests a pretty key role in how they develop.
Okay. Now, important for reassurance, what's not linked? What doesn't increase risk?
Right, good point. The notes explicitly say testicular microlithiasis, those tiny calcium deposits,
Okay.
having had a vasectomy, and scrotal trauma are not linked to increased risk.
So getting hit there doesn't cause it.
Exactly. Might make you notice something that was already there, perhaps.
Like finding a slow puncture after hitting a pothole.
Precisely. The injury draws attention, but doesn't cause the underlying issue.
Okay, so we know the risks, but what's actually happening biologically, the pathophysiology?
Basically, it's down to the abnormal growth and proliferation of those germ cells we mentioned.
Uncontrolled growth.
Yes, driven by genetic mutations and changes in how genes are expressed. It's like the normal stop signals for cell growth get disrupted.
Got it. So if someone comes in with, say, a lump, what else could it be? What are the differentials?
Ah, yes, the differential diagnosis. This is vital for clinical practice. The notes list several things to consider.
Such as?
Acute problems like testicular torsion, it's a surgical emergency, the twisting of the cord.
Needs immediate attention.
Absolutely. Then there's epididymitis or orchitis, inflammation, often from infection.
Okay, so infection or twisting. What else?
More chronic things, perhaps, like varicose, those enlarged veins.
Yeah.
Feels like a bag of worms.
Yeah.
Or hydrocele, which is fluid collection around the testicle. Testicular trauma, as we said, causes swelling. And spermatocele, that's a benign cyst.
So lots of benign possibilities, too.
Definitely. And we also need to think about less common things like lymphoma, which can sometimes affect the testes, and certain infections, TB, syphilis, even mumps or orchitis again.
So keep a broad perspective.
Exactly. Consider the range when someone presents with testicular symptoms.
Okay, let's zoom out. Epidemiology. How common is this? Let's start with the UK.
Okay, UK data first. It's classified as rare overall, but, and this is key, it's the most common cancer in males aged 15 to 49.
That age range again? Quite young.
It is. We see around 2,300 new cases diagnosed each year in the UK, and the peak age varies a bit by type.
Oh.
Yeah, teratomas, a type of non-seminoma, tend to peak around age 25. Seminomas peak a bit later, usually around 35.
Interesting difference. And globally?
Worldwide, the incidence is about 1.5 cases per 100,000 men, using a world-adjusted rate. In the U.S., the peak is slightly older, 30 to 34.
And is it changing?
Yes. The notes mention a concerning trend, a rising global incidence.
Really? Why might that be?
The notes don't speculate why, but they do point out clear variations by ethnicity and development level.
How so?
Incidence is generally higher in developed countries, lower in developing ones. The notes give stark examples. Norway's rate is high, 11.8 per 100,000. Whereas India is around 0.5, Thailand 0.4, much lower.
Huge difference.
It is. But overall, the common age range worldwide is that 15 to 40 window, with the highest prevalence really between 20 and 35.
Okay, got the picture. Now the crucial bit. Clinical features. What are the warning signs?
The number one presenting feature, by far, is a painless lump or swelling in the testicle.
Painless. That's the key word again.
It really is. While some discomfort can happen, the lack of significant pain is often what stands out initially compared to, say, infection or torsion.
What other symptoms might occur?
A feeling of heaviness or maybe enlargement of the testicle, sometimes just a sort of dull ache or discomfort in the testicle or scrotum.
Anything else?
In some cases, maybe back pain, and rarely breast enlargement or tenderness, gynecomastia.
Let's really drill down on these symptoms and signs for revision. You said over 95% present with that painless lump.
Yes, that's the classic finding. But it's worth noting, some might have testicular pain or even abdominal pain. A dragging sensation is sometimes mentioned too.
And the trauma link again?
Right. A recent injury might prompt someone to check themselves and find a lump, but it's usually not the cause itself.
Okay. Can hydrocele occur with the cancer?
Yes, it can. And gynecomastia, the breast enlargement, that can happen because certain tumors produce hormones, specifically beta-HCG.
Ah, linking back to the markers.
Exactly. And back pain could be a sign of metastasis, spread of the cancer.
What about on examination?
Well, you'll almost always find a palpable lump. And interestingly, the malignant testes often feels firmer and might lack normal sensation when squeezed gently.
And lymph nodes.
Usually the inguinal nodes, the ones in the groin, are unlikely to be enlarged in early stages. Ultrasound is really key here to help differentiate what the lump is.
Okay, so clinical suspicion is high. What investigations follow?
Right, the main ones are a testicular ultrasound that's crucial for looking at the lump itself.
To see what it is.
Yeah. Then blood tests for specific tumor markers. And imaging, usually a chest x-ray or maybe a CT scan, to check for any spread, any metastasis.
Let's focus on those tumor markers. Which ones are key?
The three big ones for germ cell tumors are AFP, alpha-fetoprotein, beta-HCG, beta-human chorionic gonadotropin, and LDH, lactate dehydrogenase.
And how do they relate to the types?
Yeah, good question. For seminomas, beta-HCG might be elevated, perhaps in around 20% of cases. AFP is usually normal in pure seminomas.
Okay.
For non-seminomas, it's much more common for AFP and or beta-HCG to be elevated maybe 80–85% of cases.
So more likely raised in non-seminomas.
Generally, yes. And LDH is less specific, but it can be elevated at about 40% of all germ cell tumors.
How do these tests lead to diagnosis and staging?
Well, ultrasound is usually the first-line diagnostic tool for the lump itself, but definitive diagnosis needs tissue.
Which means surgery.
Yes, typically via an inguinal orchidectomy, removing the testicle through an incision in the groin, not the scrotum. That gives the histology.
In staging.
Staging involves looking for spread, That's where thoracoabdominal CT scanning comes in chest and abdomen.
Okay.
And a really crucial point, elevated tumor markers support the diagnosis, but normal markers do not rule out testicular cancer.
Important caveat.
Very. Staging itself runs from stage I up to 4, depending on how far the disease has spread. Just the testes, nearby lymph nodes, distant organs, etc.
The notes stress urgency and referral.
Absolutely critical. Anyone suspected of having testicular cancer needs an urgent referral. Should be seen by a specialist within 2 weeks.
And investigation shouldn't delay that.
No, definitely not. Investigations like markers, ultrasound, chest x-ray should happen quickly, often preoperatively, but shouldn't hold up the referral itself.
And there was a helpful note about the markers.
Ah yes, a quick memory aid perhaps. AFP is typically linked to yolk sac components, so usually not raised in pure seminomas. Beta-HCG comes from trophoblastic elements, so it can be raised in non-seminomas like teratomas and also in some seminomas.
Useful distinction. Okay, diagnosis made, staging done. How is it managed?
The cornerstone of treatment, really for all types and stages initially, is the orchidectomy, surgical removal of the affected testicle.
Right.
But what happens next, the additional therapies, depends heavily on the type seminoma or non-seminoma and the stage.
Okay, let's break that down. What about for seminoma?
Right. For stage I seminoma, just in the testicle, options depend on risk. Low risk might just have active surveillance.
Watching closely.
Exactly. High risk stage, I might get adjuvant therapy, usually radiotherapy, or sometimes one course of chemotherapy to reduce relapse risk.
And more advanced seminoma?
For stage 2, where it's spread to nearby lymph nodes, adjuvant radiotherapy or chemotherapy, usually cisplatin-based, are the mainstays. For stage 3 and 4, more widespread disease, then cisplatin-based chemotherapy is the standard treatment.
Okay, that's seminoma. What about the non-seminomas, the NSGCTs?
For metastatic NSGCTs, so stages 2 and beyond, chemotherapy is key. For good prognosis disease, the standard is usually 3 cycles of BEP chemo.
BEP.
Bigomycin, etoposide, and cisplatin. For intermediate or poor risk metastatic disease, it's typically 4 courses of BEP.
Got it. Now, what if there are masses left after chemo? The notes mentioned a difference here.
Yes, that's an important point. For non-seminomas, if markers have normalized but CT scans still show residual masses, surgery to remove those masses is usually recommended. They might contain active cancer or teratoma.
Okay, and for seminoma?
It's different. For residual masses after chemo for seminoma, the usual approach is observation with imaging. These masses are often just scar tissue or fibrosis.
Interesting difference in approach. What about fertility? Surgery obviously impacts that.
Hugely important consideration, especially given the young age group often affected. Sperm storage, or sperm banking, is routinely offered before orchidectomy.
To preserve future options.
Exactly. And cosmetically, a testicular prosthesis can be offered after the orchidectomy.
And follow-up, it doesn't end with treatment, right?
Definitely not. Regular follow-up is absolutely essential, usually for the first 5 to 10 years. These visits monitor for any signs of relapse so it can be caught and treated early.
And support.
Vital. Fertility counseling, links to support organizations. These should be offered. Monitoring semen quality before surgery helps inform those fertility discussions too. The follow-up visits are key for monitoring and ongoing support.
So wrapping up management, orchidectomy first, then tailored therapy based on type and stage, consider residual masses differently, preserve fertility options, and commit to long-term follow-up.
That's a great summary.
Okay, after all that, what's the outlet, the prognosis?
Generally, the prognosis is very good. Excellent, actually, especially when caught early.
High survival rates.
Yes, overall survival rates are high, exceeding 95% for localized tumors, stage I. But, as the notes say, it does vary based on the type and the stage at diagnosis.
Can you give some specifics from the notes?
Sure. For stage I seminomas, the 5-year survival is around 95%. For stage I teratomas, a type of non-seminoma, it's still very good, around 85%.
It's still high.
Very high. But it highlights that NSGCTs as a group might have slightly less favorable outcomes than pure seminomas, stage for stage. And the notes mention choriocarcinomas, a rarer type, as having the poorest prognosis.
And underlines the importance of early detection again.
Absolutely crucial. That's why public health messages about self-checks are so important, and why people with known risk factors, like cryptorchidism or family history, need to be aware and vigilant.
Right. Now, even with successful treatment, are there potential long-term complications?
Yes, unfortunately there can be. Metastasis, the spread, is the obvious complication if not caught or treated effectively. Infertility is a risk, especially with bilateral orchidectomy or certain treatments, and there's a slightly increased risk of developing second primary cancers later on.
The notes elaborated a bit more on long-term life quality.
They did. Thankfully, most survivors get back to a normal quality of life. But potential issues exist. Hypogonadism, low testosterone, and reduced fertility can happen.
Side effects from treatment.
Yes, long-term chemo side effects like neuropathy, nerve damage, or hearing loss can occur with cisplatin. And as mentioned, a slightly higher risk of certain other cancers later.
And cardiovascular risk.
Interestingly, yes, a slightly elevated risk of cardiac events, noted as being similar to long-term smoking. And while overall quality of life often matches the general population, some individuals might struggle with anxiety, financial worries, maybe alcohol misuse, or sexual difficulties post-treatment.
And late relapse.
It's rare, but it happens. Relapse occurring more than 2 years after chemotherapy happens in maybe 2–3% of patients. And these late relapses can be less responsive to further treatment.
Okay, well, that's a really comprehensive run-through. We've covered a huge amount. To boil it down, what's the core message for our listeners revising this topic?
I'd say the key things are, testicular cancer is serious, yes, but it's highly treatable, especially with early detection. Knowing the risk factors and, crucially, recognizing the signs, particularly that painless lump, is absolutely vital for getting that early diagnosis and the best possible outcome.
Excellent. A clear message. If you, our listener, want to review these points or have more questions, you can always revisit this deep dive. And for MSRD prep or just expanding your knowledge, definitely check out passthemsra.com.
And freemsra.com too, both great resources.
Absolutely. They offer fantastic support and practice materials.
Invaluable, really.
So a big thank you to the listener who sent in these notes. It's always good to tackle material that's, directly relevant to what you need.
Definitely. Keeps us focused.
Until our next deep dive then, keep learning and keep those notes coming.